Welcome to the first Clinical Trial Symposium. We're very excited to see all of you here and expect that each one of you will leave at the end of the day with a renewed energy for conducting your own clinical trials here at Downstate. For those of you who have been here for years, you will notice a lot has changed, certainly since I've been here in 2014. We are working diligently to remove silos, offer resources, and provide tools so you're able to successfully conduct pharmaceutical clinical trials. We are happy to offer this symposium and are looking forward to your participation and feedback. Please look out for a survey, which we'll be sending out in a few weeks' time. As you'll see for yourselves, there is a significant amount of support from leadership for research activities on campus and clinical trials in particular. There have been a few last-minute changes to the agenda. Dr. Bunicardi is not able to attend, and Dr. Lazar will be providing welcoming remarks from the College of Medicine. Unfortunately, Dr. Berger is out sick today and won't be able to join us, as much as he was looking forward to it, and welcoming all of you to spend the day with us. So without any further delay, please join me in welcoming Dr. David Christini, Senior Vice President for Research.
Thank you, Sharon. And before I forget, I want to just acknowledge and thank Sharon Seeley, Dr. Marcus Lambert, Dr. Aisha Joshi, and Tirtha Ratnam, who have been just working very hard to put today together. And I hope that you all, I'm confident that it's going to come together really nice, and I think you'll all really enjoy today's events. So I'm really excited about today because it really marks, I think, a point that we've reached at Downstate after 3+ years of effort to try to really solidify and strengthen our efforts around clinical trials. If you go back 3 years or so, things were basically happening more or less ad hoc, and clinical investigators, clinical researchers had to kind of figure things out on their own. We've worked really hard in trying to reduce the burdens, the administrative burdens, put in place agreements to try to make it so that our clinicians who are researchers or who want to become researchers have to deal as little as possible with the administrative burdens and the paperwork. We all know how strapped clinicians are for time, and so we need to make it so that they can focus their limited available time on the actual research project. So in doing that, what have we done? We put in place a clinical trials office. We're happy to recruit Yehenu Abitu, who's right here in the front. Also, I should have acknowledged, thank you for your efforts in putting today together. And beyond that, for everything Yehenu's done. We didn't have a clinical trials office before. Yehenu's the director of that. We have a clinical trial study coordinator program, so the Research Foundation provides funding to make sure that we have on staff a number of clinical trial study coordinators so that people don't have to start the process of finding and hiring somebody when they get a new clinical trials. We've put together a clinical trials faculty advisory committee chaired by Dr. Steve Levine, who's over here, that is really aimed at thinking strategically about clinical trials as well as operationally advising us on what we could do better. We are also working a lot with our other SUNY campuses, especially we've been doing a lot of work with Upstate to try to align better on clinical trials opportunities. We all know here in Central Brooklyn, we have we have an underserved, underrepresented population. Our hospital is something like 88–90% underrepresented, and so that's both core to our mission to be able to serve that community, but also a real opportunity for us as an institution in terms of attracting clinical trials. So it's a bi-directional situation. SUNY, as a larger entity, is stronger and more attractive to clinical trials entities if we can sort of band together so that they only have to negotiate ideally like once, and they can work together with the Central Brooklyn population, the rural population up and around Syracuse, populations at Stony Brook, et cetera. So we're doing a lot of work in that regard as well. We're also working with our partners. Dr. Kevin Becker's here, who has a joint position both here at leading the HEMONC division as well as at Maimonides. So there are real opportunities to have more clinical trials that involve the patient population, a slightly different demographic at Maimonides. We've also been working a lot with Kings County. There've been a lot of barriers over the years that are sort of make you scratch your head, like, why can't we get this done? Sharon Seeley has been working really hard with counterparts at Kings County to put in place a master agreement, and we're confident that we are now going to be able to very soon have clinical trials that are seamless. There have been a number of clinical trials on both sides of the street, but it's been really an ad hoc arrangement. We're trying to make that easy. So those are a few of the things that we've done. I'm hoping that today will help educate some of our clinicians who might not yet be active in clinical trials or who have tried in the past and have run into barriers about what we're doing and how they can get more involved so that we really can make the difference that I'm confident we can for Downstate and for our patient population. So I feel like we have a lot of momentum, and I'm really excited about today and everything that we've done. So with that, I will introduce Dean Jason Lazar, who is the interim dean in the College of Medicine now for 11 days or something like that. He has an incredibly busy schedule because he was vice dean before that, and he's an active cardiologist. So, but somehow he finds, if you need something done, you assign it to a busy person because they seem to be able to find some more minutes in a day. So he's a great colleague, and the commitment to from the College of Medicine in clinical research and clinical trials is very real, and I think we have a great partnership. So with that, Dean Lazar.
Thank you very much. It's actually 11 days, 1 hour, 12 minutes, and 37 seconds. Dean Brunacardi, as many of you know, is away on medical leave. I just wanted to share with the group that he is doing well, and we are all looking forward to his return, especially myself. I want to congratulate the entire team that put today's session together. This is really an amazing event. And I thought what I'd do is take a minute and give you my perspective of 30 years of an academic career in terms of clinical trial involvement. And I've been someone that has participated in clinical trials. Admittedly, I've never run one. I've not taken that on. And while clinical trials are viewed as research studies aimed at testing new drugs, surgeries, procedures, and therapies, I'd like to contend that they are much more than that. First off, they are the results of years, if not decades, of scientific investigation, usually starting in the basic science arena. They're absolutely a single point in time that is really reflecting a lot of hard work before that. They're also the application of science to patient care. And that in itself is a multidisciplinary approach. And what does a multidisciplinary approach do? It brings in different perspectives, and in my opinion, it broadens our perspectives and it enriches our jobs. Clinical trials are based on existing paradigms, and not only do they perpetuate those paradigms, but I would contend that they challenge underlying assumptions. I remember my first year of cardiology fellowship in training. We gathered in this big symposium hall in New Orleans. By the way, a place that I find very difficult to perform any kind of cognitive function, but nonetheless. And there I was, gallivanting through the halls, trying to figure out which of the dozen presentations to go to. And someone took me by the arm and said, hey, they're going to release the results of the CASS trial. I don't know if any of you know the CASS trial, but it is not a trial about plaster of Paris on limbs. The CASS trial stands for the Cardiac Arrhythmia Suppression Trial. At the time, many people were having myocardial infarctions, heart attacks, and a large number of those patients had premature ventricular contractions. And those that had PVCs, I'll call them, did worse. They were at a much higher risk for sudden cardiac death. More PVCs, the higher the risk. So we began the paradigm, PVCs are bad, PVCs are bad, PVCs are bad, PVCs are bad. We knew they were bad. Many of them were symptomatic. A lot of our patients had palpitations, and along came a number of drugs, two of which, enconide and flecainide, I call them the Ide brothers, if you will, came along, and these were drugs that were magical. They eliminated PVCs. They almost erased a Holter monitor, a tracing, and made it almost perfect. 98% of PVCs were abolished. They went away. Patients were raving about these drugs. They were fantastic. 5,000, 6,000 PVCs a day would go down to 50. And by the way, more than 10 an hour, 240 a day, were associated with a much worse prognosis. Well, there I sat in the audience. My first observation of a clinical trial being presented to a large national audience. And these drugs were effective. 95% abolishment of PVCs. And you know what? There was a 2 to 3-fold decrease in mortality in the placebo group. The drugs abolish PVCs, but yet they worsened outcome. 2 to 3 greater fold mortality. It wasn't the PVCs that were killing people. They were a marker. And much like a California highway, and I have a slide of this, with the slippery when wet sign, if you eliminate the slippery when wet sign, sometimes things even get worse. So once again, I would contend that clinical trials are not just to test a specific therapy in a very focused area, but they challenge underlying assumptions. And what does this do? This perpetuates a refinement, a cycle of refinement of our understanding of complex medical issues. So I think that there is way more to be gleaned from clinical trials, and there was never a better time to put this symposium together. And I want to thank Dean David Christini, Ms. Sharon Seeley, Dr. Aisha Joshi, Ms. Tirtha Ratnam, and Dr. Marcus Lambert for all of their hard work in putting this together. Simply put, clinical trials are really the dark matter of our universe of the medical establishment. And lastly, on behalf of the entire Dean's Office, we wish to pledge our unwavering support to our colleagues in the Research Institute, and to welcome an old friend and a Downstate alumnus, Dr. John Bukva. So thank you very much.
Good morning. I have been given the honor of introducing our keynote today, and what an honor it is, because I have had the opportunity to work with Dr. Bukvar in my former employment at Northwell for many, many years. And we've gone through the battle of COVID together, and I guess we've got the scars to show for it. So it's been an honor, and it is an honor to introduce him. Dr. John Bukvar is the Vice Chair of Department of Neurosurgery at Lenox Hill Hospital and the Director of Department's Brain Tumor Center, the Pituitary Neuroendocrine Center, and the New York Head and Neck Institute at Lenox Hill and Manhattan Eye, Ear, and Throat Hospitals. Dr. Bukbar is a professor of neurological surgery and otolaryngology. I know I messed that up, sorry. Head and neck surgery at the Donald Barbara Zucker School of Medicine at Hofstra in Northwell. He is also investigator at the Feinstein Institute for Medical Research, where he directs the laboratory for brain and tumor biology and therapy. Dr. Bukbar was appointed to adjunct professor at Cold Spring Harbor Laboratory thanks to his great advancement in understanding and treating cancer. He is also head of experimental therapeutic at Northwell Health, where he helps oversee the oncological research for all of Northwell Health. Dr. Bukbar's compassionate cancer care was recently highlighted in the critically acclaimed Netflix docuseries Lennox Hill and Emergency NYC. If you guys have not seen it, it is a binger. I highly recommend it because I saw it in 2 days. Dr. Bukbar is an internationally known for his surgical expertise and for providing patients with safe, effective, and minimally invasive treatment for brain tumors, skull-based disorders, and disorders of the spine. His surgical expertise is in benign and malignant brain tumors, skull-based and endoscopic pituitary surgery, spinal and peripheral nerve tumors, minimally invasive spinal surgery, and complex spinal disorders. Dr. Bukbar has been recognized for his novel research in brain tumors and stem cell biology, and he has been named to the list including New York Magazine's Top Doctors, Best Doctor in New York, Castle Connolly, New York Super Doctors 2015 to 2023, America's Top Surgeon, American Best Doctor, and America's Best Doctor for Cancer. His research has been widely published, and he has received numerous national and awards, including the Eric Lichtenstein Humanitarian Award for Voices Against Brain Cancer for his compassionate work in treating patients with brain cancer. In 2016, Dr. Bukbar was elected to the prestigious Academy of Neurological Surgeons, and the following year, he was elected to Senior Society of America Board of Neurological Surgery. Dr. Bukbar is also an honorary surgeon for the NYPD and the New York State Troopers. Without further ado, please help me welcome Dr. John Bukbar.
First of all, Yanu, thank you for the invitation. And I just want to echo Dr. Lazar's point that, first of all, it was 30 years ago that I was here as a medical student, which is just crazy. And every time I come back here, I can't help but realize the opportunity that Downstate has, particularly in this community, in this county, and in, of course, this borough, the state. And it really is exciting to know that a clinical research day has sprouted. So, Yehanu, thank you for the opportunity. I got to tell you one quick clinical trial story about what we went through during COVID, which I think is really an important story. We had a pretty robust clinical research enterprise at Lenox Hill Hospital in March of 2020, but we were siloed. Yehanu was doing his work, cardiology, and I was doing my work in neuro-oncology. And then all of a sudden, March 6th came, which was a Wednesday of 2020. And if you remember, that was sort of patient 2 had just been diagnosed with COVID in White Plains, New York. And sort of the world started crashing around us. And Lenox made the decision that we were going to shut down all clinical trials, but all the clinical research effort was going to be geared toward COVID. So we had to all of a sudden coalesce as a group, and I'm going to get emotional thinking about this. We started running clinical trials for COVID. None of us knew anything about COVID. We didn't know anything about the transmissibility of COVID. And all of a sudden, we started meeting every morning with our pulmonary doctors and getting lists of all the patients who came in the night before with COVID. So Yehanu, myself, Tamika Wong, others in our research enterprise would meet every morning, and we started running, and I wrote a clinical trial for low-dose naltrexone for COVID. It was rejected by our institution, but nonetheless, we started being provocative in our thought process, and it brought us all together. And I can tell you that we had to don these big sort of orthopedic cap and gowns. We were fully covered in these masks. They weren't just masks, we were robed, essentially. And you can imagine these patients were coming in, they were elderly, they were alone, and we had to get them to sign consent. And we had to get close to them. So they were vented. We couldn't communicate with their loved ones. We had to ask for their consent. We were doing trials from everything from IL-6 inhibitors to Pepsid, famotidine. I mean, we were just piling it on. But it was a really impactful time and actually brought us all together. And actually, we published significant papers regarding that. And it all started in the clinical research group. So if there's one thing that brought us all together, it was a very painful time, but a really powerful time. That's my anecdote to start. So it's great to reflect on those times. Okay, so I'm not going to bore you with sort of glioblastoma basic science, but what I'm going to do is walk you through my understanding of the disease and how it relates to the clinical trials that I've worked on for the last 20 years. And it started as a student, and I think that's an important statement. You know, when I look at this slide about Northwell Health, it's a very confusing entity, and I'm not here to explain it, but it's large, it's big, it's good for the most part. I'd like to say it's the least shitty health system out there, but what's good about it is it has removed some of the red tape for clinical research. And I was very happy in New York Presbyterian, but there was red tape and it was slodgy and I couldn't get stuff done and it was risk averse and I got tired of it. So Northwell, and I hope that Downstate takes that mantra of greasing the wheels, because it becomes a business strategy. How do I get patients with cancer? Why would they come to Lenox Hill Hospital where, you know, you got your knee scoped or you delivered babies, you didn't get your craniotomy for a brain tumor, you went to Sloan Kettering, right? So that's an important business strategy in addition to important research. So again, I have a ton of people to thank, and it's a continuing work in progress. You know, my wife always asks me that when I'm preparing for talks, she goes, "Don't you know the talk already? Why are you preparing?" I said, well, because it's an evolution. It's like continuing to build your resume. You have to keep updating it and understanding it, and it's an important thing. Okay, so I keep going. This is delayed a little bit, so I apologize. So my life is sort of a confluence of all these things, and it starts with great people. And in the middle, up top, that's it, is our original clinical research team that started at Lenox Hill Hospital. And this is a hospital that never did clinical research before. So now we went from zero. We run 33 human clinical trials. We're the busiest clinical trial program in the country for our disease subspecialty. And we just kept pushing. And when people said no, we knew that was a reason to push harder. And when people said we don't do that here, we said, well, we're going to do that here, and we're going to help figure out how to do that. It does combine a basic science effort, which obviously Downstate has plenty of. My basic science research starts at the Cold Spring Harbor now. It used to be at Feinstein, and for various reasons, I moved over to Cold Spring Harbor. So this is just a little bit of our research. Like I said, we have over 35 trials now of all different types. Tamika Wong is our Yehenu. She has been with me working in our clinical trials office for 11 years. There's not a thing that she doesn't know. You need a Yehenu here. You need a Tamika. You need someone who's going to really be the go-to person for all docs, all nurses, PAs, administrators, whoever it is. There has to be people that know exactly what to do. And I'm grateful every day for that. But more importantly, I think was mentioned earlier, all of our docs now are doing clinical research, every single one. In fact, it's part of our ethos. If you're not doing clinical work, you kind of have to tell me why, because we want that side of you to really flourish. And also in the age of social media, obviously Netflix, and I didn't get paid a cent for Netflix, but it did provide us a platform to tell the world what we're doing, and that was really an incredible opportunity. And now with social media, with IRB approval, my patients love being on social media. And if you follow me on Instagram, I'm not asking you to follow me, but like me if you do. No. We put our patients on social media, and the importance of that is I can't understate it, because foundations love it. The brain tube, and I have 12 foundations that are very, very tied to our social media presence. So it becomes a bit of a flywheel effect. You get a patient on a novel clinical trial, you put it out on Instagram, Facebook, Twitter, whatever it is, it just starts multiplying. All of a sudden your phone starts ringing. Hey, how could I get on this vaccine trial? How could I get on this interventional cardiology trial? Like, this is where it's going. And it has to start here. And honestly, it makes work fun. Like I said, all of our 6 out of 9 of our attendings are PIs, 7 of 9 are co-investigators. Our NPs are actively involved. I had an NP write one of our clinical trials, and she came from Columbia. She had an idea, and she wrote the clinical trial that's still going on today. My NP was so good, she got asked to be chief nursing officer at the Kimmel Cancer Center in Jefferson in Philadelphia. So I expect all of our staff to get opportunities like that. And frankly, when you have that clinical research expertise, you become invaluable. And we publish. So my focus, and I'm not going to bore you with the problem, but I think about this clinical problem 24/7, and it is a really challenging problem, which is glioblastoma. Glioblastoma is a malignant brain cancer in adults. It does happen in children. The survival is abysmal. It's probably the most lethal of human cancers. We do surgery. Here you can see a fungating case of a glioblastoma fungating out of the human brain. We do surgery, radiation, and chemotherapy, but it's woefully ineffective, and 2-year survival is only less than 25%. And really, there are 2 reasons for that. One is the blood-brain barrier. My whole goal in clinical research has been to overcome the blood-brain barrier. So if I were to summarize my research, it is overcoming the blood-brain barrier. Here you can see a classic glioblastoma. Basically, I remove this right. My left is the patient's right, so this is a right occipital brain tumor. I remove it, and invariably, it's not showing the next slide, but the patient gets radiation and chemotherapy, and then it comes back, and the patient usually lives about 12 to 15 months on a median survival. And when I think about clinical trials, these are the trials we have in GBM. Now, I know in cardiology there are many more clinical trials, but remember, GBM patients are only 13,000 patients per year in the United States. So you can see these are large, randomized, controlled trials for glioblastoma. They consist of radiation and radiation in TMZ, which is called temozolomide. But frankly, we've improved survival from GBM, listen to this stat, 1 month for every decade of research. So 5 months over the last 50 years, we've seen an improvement. That's really not good. So our patients, for 50 years of research, have only gained 5 months of survival. And there's a whole host of drugs. You've seen these, but cancer is key. And if you talk to the administrators of any hospital, cancer is one of the big 4 moneymakers, right? And the idea of and people, cancer is also elective, meaning that patients get an unfortunate diagnosis, they go on the internet, and they can choose their provider. And whether it's here in Brooklyn or in Manhattan, they want to know who is going to cure their cancer. They don't care where it is. They don't care what flag that health system is flying. They want to know that that trial is going to cure them of cancer. And if Downstate becomes the Brooklyn hub for cancer, which it should be, you're going to have all these trials for a whole host of cancers, okay? I was looking at cancer stem cell biology. I'm just going to flip through this. So my lab, Dr. Lazar mentioned some of these ideas started from my passion in the lab. So I would take all these brain tumors out, and we'd send them to the lab at Cornell, and I would isolate all these glioma stem cells. All cancers have stem cells. They're the undifferentiated, immature cells that are in every cancer, whether it's breast, colon, brain. And there's a big biotech push in glioma stem cells. And so, again, another avenue So my other nurse practitioner who ran our clinical trials, she decided to take a step into biotech and healthcare life science. So she now is head of global affairs for Integra Bioscience. So again, she ran our clinical trials department for 7 years. Her name is Cherise Fralin. And she then was so marketable that she now runs global affairs for a big biotech company. So there's a lot of great opportunity. And I love, that's what people don't know. It's like the hidden secret of clinical trials. Like there is a lot of opportunity. I'm not telling you guys to leave, but keep your resumes shiny. Anyway, these are glioma stem cells that reside in the perivascular space. You can see these green cells right here. So these are the cells that I've always been interested in brain tumors. So we all have these microcapillaries in the brain, and these glioma stem cells reside in this place called the perivascular stem cell niche. So I started thinking that these were the cells that were causing and maintaining brain tumors, and we couldn't get to them. So I thought about ways that we should overcome the blood-brain barrier and bypass this blood-brain barrier and kill these glioma stem cells. And these glioma stem cells reside right here in purple. So this is the idea. How could I kill these stem cells right here? And again, the blood-brain barrier is under-researched. So any of our students who want to really, and I see one of my favorite students, Hamza, in the back over there. If you want to do a great project that is under-researched, look at the blood-brain barrier. I mean, the blood-brain barrier was described in jaundice patients. When they, at autopsy, all of their organs were yellow, except the brain. So someone said, oh, well, why is that? And it's because bilirubin never bypassed the blood-brain barrier. So that is an incredibly important structure that prevents just about any treatment from getting to the human brain. And there are many ways to bypass the blood-brain barrier. I'm going to talk to you a little bit about enhancing the blood-brain barrier using osmotic diuretics that basically pull the endothelial cell apart. And we do that with a drug called mannitol. I'm going to skip some of this stuff in the interest of time. But this is a classic brain tumor. This is a 62-year-old. Again, my right is the patient's left because his legs are coming out of the screen in the MRI machine. But this patient at 62 basically has an 8 months to live. It's a dominant hemisphere thalamic GBM. Well, he's still alive about 8 years later, and he enrolled in our clinical trial. And you can see what's left of this big thalamic brain tumor here is now this little smudge, okay? He was working and still alive and in good shape. And the reason, in my belief, is that he enrolled in one of our early clinical trials using intra-arterial drug delivery to the human brain. And I'm going to skip through some of this basic science, but I'm going to go back to this stem cell. Intra-arterial delivery is different than intravenous or oral. Intra-arterial is where you use the feeding vessel to an organ, whether it's the liver or the brain, and we feed drugs directly into those arteries so we kill those glioma stem-like cells. And those stem-like cells release a host of tyrosine kinase stimulators like VEGF, vascular endothelial growth factor. Those little green cells cause proliferation, protection against radiation, and cell viability. So I had to go after those green cells. We did basic science with the drug in the lab before we went into humans and found that the drug bevacizumab was the best choice for killing these green cells. And you can, all of this is in preclinical animal models. And ultimately showed that we got the dose that was required for these preclinical trials. And then I decided I had to run the human clinical trials. And this was at Cornell. Now, Cornell and New York Presbyterian, I don't know if you know the history of Cornell, but I'm happy to share it with you. They're very risk averse. Why? Because when the famous Libby Zine case in 1988 was, unfortunately, a woman named Libby Zine came into Cornell. She was on certain medications, and a resident who was up for the 128th hour of her week had the wrong decimal point in her drug that she was given that night. And so that started the Bell Commission, which then restricted resident work hours to 80 hours a week. So it's a very risk-averse place because that's sort of where the entire medical education of residents changed. So I knew they were not going to be happy with doing something that's risky. And I asked them to, I wrote an investigator-initiated trial using intra-arterial drug delivery for brain tumors with blood-brain barrier disruption. Now, you can imagine being a reviewer saying, Dr. Bookfarm wants to, open the blood-brain barrier. Isn't that going to cause massive hemorrhage? And the answer is, I didn't know. But I knew I had to try because the treatment in humans was inadequate. So the intra-arterial drug delivery opens the blood-brain barrier. Here you can see the opening between the endothelial cells. I wanted to get this high dose of drug into the area where these stem cells were and deliver high doses. And so that took me 1 year to get through the FDA. And then I had to put it through the IRB, which took another year, okay? And then I'll never forget, I don't do intra-arterial drug delivery. My partner at Cornell did it. And then I finally consented, my first patient in 2009. And my partner at the time, Howard Rena, who's now at NYU, called me the night before. He said, John, I'm really scared to do this procedure for you tomorrow, opening the blood-brain barrier. He says, we're going to kill somebody. I'm like, Howard, I have the preclinical data. I went through the FDA. I went through the IRB. Patient signed consent. If you don't want to do it, I'm going to get somebody else to do it. He goes, hold on, I'm going to call somebody from the West Coast who's an expert. And the guy on the West Coast, who was his mentor, hung up the phone with him and said, you're going to kill somebody. So at which point, I was operating. Howard calls into the operating room, and he says, we're going to kill somebody. I'm like, we're not going to kill somebody. We're going to do this tomorrow. And that kind of pressure and stress, and I stared at the ceiling, that night saying, is my career over? I'm a junior investigator. I just wrote this sort of novel IIT. And there's stress, and there's peer pressure. I always say this to the students. There's a lot of peer pressure in medicine. I don't know if you know that, but are you doing the right thing? Are you going to hurt somebody? Maybe it's too risky. You're not doing what other people are doing. So the peer pressure never ends. But we did it. Here you can see a microcatheter in the vessel delivering the drugs into a brain tumor. So that's the idea of intra-arterial drug delivery. Here's just a schematic of it. You're opening the blood-brain barrier with a drug called mannitol and delivering high doses of drugs while these endothelial cells are pulled apart and delivering a high dose of drugs. Okay, and I think I have this is an example of the angiogram that targets that tumor. And here's an example of how thin those blood vessels are. Look how cool this is. This is about the size of a hair follicle. This is a microcatheter that's going into the brain. And this is a feeding vessel to the area of a brain tumor. So the idea of intra-arterial drug delivery is all the drug is getting into this area. All right, believe me when I tell you that we thread a microcatheter through the groin up into the brain and shoot that area that I showed you here with high dose of mannitol to break down the blood-brain barrier, and then coat this entire surgical cavity with intra-arterial bevacizumab in this case. And sure enough, what did we see? We saw really positive results. We improved the progression-free survival. So remember, we went from, like everything else, you start in phase 1, where we had to get the dose. We did a standard 3x3 design. Then we moved to phase 2, and we saw a signal at the highest dose with the standard 3x3 design. We moved on to phase 2, and then this allowed us to publish, right? So our mantra is not just clinical volume, but publish, move the needle in, and we got everyone involved: nurses, doctors, PAs, research staff. You can see down here, like I said, here's my nurse practitioner, Charisse, who went on to great things. Mona Lee went to Dana-Farber, now runs the research. Do you remember Mona? She runs research at Dana-Farber now. Tamika, obviously, is head of our clinical research for Northwell. Lucas is a medical student. So, like, publishing just leads to great things with great people. So, what's also great is when people start believing you, right? So nobody believes you in the beginning. And so when this paper, came out from Johns Hopkins, none of this was my data, but I ran around screaming in my house, I told you so, I told you so, because this was done in animal models, and I was doing it in humans, which is ironic. And also publishing this, you have to overcome the naysayers. And when I saw this paper out of Hopkins, which was basically proving in mice what I had spent the previous 9 years showing in humans, was really important for us. So here's our trial. We're now in phase 3. So it took me a decade. So just to let you know how long it takes so you're not frustrated, It took me a decade to open a phase 3 trial. So this is investigator-initiated a decade later. We give 3 doses of intra-arterial drug delivery. We did our phase 2 trial with 33 patients, I think, or 31 patients. And here's the results of our phase 3 trial. This was just recently a cover article in the Journal of Neuro-Oncology. So again, having that peer recognition is important, particularly when you start recruiting. And when I have to ask the FDA to go to phase 3, it's very important. But most important, when you start seeing improvements of survival and your patients living longer, it's very satisfying. So here we moved the needle from 12 to 15 months to a median of 24 months, 23.1 months. So essentially doubled the median survival for these patients. That's impactful. Now, remember, in glioblastoma, we're not talking about many years of survival, but trust me when I tell you, if you can keep the father of a middle school girl, and this is a true story, alive until she graduates high school, really impactful. It's very different to lose a parent when you're in middle school compared to when you're in college or something like that. Every year matters. And these are just some examples of our tumors that we just saw disappear from our treatment. So here we are today at a phase 3 randomized this is a randomized to standard of care trial, so we're now open. We have about 4 patients of 206 in the treatment arm and 103 in a control arm. So again, it took me a decade to get to this randomized multi-institutional phase 3, but guess what? Our institution is a lead site. We, at the Feinstein Institute is our CRO, so it just makes everyone feel good. It's a very sort of inclusive environment. And then we rolled this out with other drugs. We started looking at cetuximab. Cetuximab is the drug that put Martha Stewart in jail, so we know that it's a good drug. We started using it in brain tumors, and then we started looking in kids, and we published it at Cornell for diffuse infiltrated pontine glioma. And this was recently published in the Journal of Pediatrics and Neurosurgery. Again, impacting, this is Jenna Chiavelli, who allows me to use her. This is a great video, but she was paralyzed and was sent from Dana-Farber into hospice care. She came down to us for intraarterial bevacizumab for her glioma, and then about a month later, she got out of her chair and started walking, and then about 2 months later, she's in Bermuda with her family. Very important and impactful. So that's sort of a summary of a decade's worth of how I got from an idea into a phase 3 trial, and it is exhausting. Absolutely exhausting every step of the way. But it's people in this room that allow it to happen. But there are a lot of benefits. What are the benefits? Patient outcomes, right? Safety and efficacy is the most important. Academic excellence at all levels, from the clinical coordinators all the way up to the physicians. It's a business for the institution. We get patients because of these trials. Okay, so it just fires on all cylinders, and of course, it makes us all feel good. So I'm going to end on another just even riskier approach to clinical trials. And ultimately, when you deal with a deadly terminal illness, you can take some risk. So I understand that I'm dealing with glioblastoma, and there is this nihilism about glioblastoma, meaning that they say, well, the patient's going to die anyway. You can do basically anything. That's not really fair to the patient. So we are very, very careful about what we offer our patients, and we don't treat them as experimental subjects. But we do have to take some risks, and I have a serious discussion about these new trials that we started a couple years ago, right before COVID. And actually, it was very painful for our patients. You can imagine when patients are coming to me during COVID. COVID was a terrible time, obviously, but it was a terrible time if you had cancer or you were looking for a clinical trial, or if you were hospitalized. And I'm sure many of you were touched personally by this. But you can imagine that patients were reaching out to me, and I had to tell them our clinical trials are not running. And they were dead by the time COVID ended, you know, and they were dead alone in hospital beds all over the country. So it was just absolutely terrible. I started working with, I think it was, I forgot who it was, that said, never go to a conference in your own discipline. You learn much more by going, like I should be going to cardiology conferences because I would learn the technology and the techniques. The neurosurgery conferences are terrible, right? like to hear themselves speak, but actually cardiology is about a decade ahead of neuroscience, essentially, just from volume of patients. Anyway, our ENT colleagues at Lenox were doing a unique way to fight off osteoradionecrosis of the skull base, and they were raising these large tissue flaps called temporal parietal fascial flaps. And what these do is they provide a large vascular pedicle, and you basically put them on any bone, anywhere in the head and the skull. And if you have osteoradionecrosis, which many patients with head and neck cancer have, this is a great way to treat ORN, osteoradionecrosis. You basically take this vascularized pedicle flap, you put it on whatever necrotic tissue you have, it provides antibiotics, it provides healing and wound care. It's called the temporal parietal fascial flap. So I was doing a big right frontal brain bleed one day, and I took out this big bleed, and I'm holding this big pericranial flap that I had harvested because I actually wanted to use it to repair the dura. And this woman who had bled, it wasn't a stroke, it was actually a large glioblastoma that had hemorrhage. And I'm holding this big piece of pericranium, and I said, gosh, the entire flap is filled with blood vessels that don't have a blood-brain barrier, meaning that it's extracranial. So all of these blood vessels lack a blood-brain barrier. So I sent my student, and Juliana's my current student, but my student at the time was Lucas. And I said, Lucas, I'm sure someone's have thought about this already, but go and search what happens if I lay this pericranial flap on the human brain, and maybe the blood supply in this flap will anastomose with the microenvironment of the surgical cavity, providing a conduit for us to deliver drugs and immune cells. And sure enough, he came back, he said, it's never been done. So this is a little cartoon that I had one of my fellows do. The idea is you raise this temporal parietal fascia flap. All of these blood vessels lack a blood-brain barrier. I take out a brain tumor, and then I stuff this flap into the human brain. Now, you can imagine the risk. What are the risks? It's always the 3 S's in neurosurgery: seizure, swelling, and stroke. Seizure, swelling, and stroke. What if I put that flap in? It causes seizure. What if I put that flap in? It causes swelling. What if I put that flap in? It causes stroke. But again, here's another example. This is a real human case, right? The idea was I take out a brain tumor, I have this perivascular temporal parietal fascial flap, all these blood vessels, and I basically stick it to the surgical cavity. Now, any cancer has something called tumor-associated antigens, where you're releasing antigens into your immune system, every tumor, right? Whether it's HER2 in breast, whether it's colon cancer, brain cancer, whatever, we all have tumor-associated antigens. And one day, I believe that our immune system is going to be the only thing that cures cancer, right? Our immune system is the thing that keeps COVID away. When we recognize the spike protein on a COVID virus, that our immune system is educated. So we need, and in the brain, which is immunoprivileged, our brain is not seeing tumor-associated antigens. So the idea of this flap is twofold. Now I have a conduit that doesn't have a blood-brain barrier, so lymphocytes can infiltrate this area and recognize tumor-associated antigens, and I can give Temodar or IV drugs, and it will get into this area. So here's an example of one. You see this large pericranial flap that I'm holding with my fingers? That's how big it is. This is basically right along the forehead. Pericranium is like a carpet pad for your scalp. So under the scalp is a carpet pad. It's called pericranium. And so the idea is I elevate this and I put it in. There's a video here, but I have to skip it. So what did I do? I had to convince the FDA that I could do this, right, at Lenox Hill Hospital. There's no preclinical data. There's no animal data. In fact, if you go back, there have been some NIH studies where they took muscle and put it on the brain. But I do know we as neurosurgeons do something called the omental cranial transposition. I know it sounds like a mouthful, but we take omentum from the human belly, we tunnel it under the skin, and we put it on the human brain for patients with strokes or moya disease. I know it sounds crazy, but we do it. And actually, there are trials now for Alzheimer's disease and stroke. So part of, I know this sounds terrible, the FDA is not the smartest organization all the time. So you have to spin your trial in a way that makes scientific sense. And basically, I spun the omental cranial transposition data and said, well, that's safe. This pericranium should be safe. And they let me do it on 10 patients, humans, with GBM. By the way, I'm skipping all of the paperwork that Tamika Wong had to do 1572s and just over and over again. So having the infrastructure here to do IITs like this is really important. And having the clinical coordinators trained in this is really, really important. Like, so important. I would not be standing here without it. So here's a case. Here's a big left frontal brain tumor. What you can't see is in this surgical cavity is a big pericranial flap. And this patient, here you can see my pericranial flap on my blue towel. And here is a surgical cavity with the pericranial flap stuck. And I put some glue on here as well to hold the pericranial flap in place. Again, we put the bone back on. Here you can see I actually removed this 2 years later because the patient had a recurrence around the flap. So I was able to go in and remove this flap 2 years later. Absolutely fascinating. Because look what we found in the pericranium. Just what I had hoped. It was infiltration of immune cells that weren't in the vicinity of the tumor beforehand. Again, these are called tumor-infiltrating lymphocytes. So all of this stuff, macrophages, remember, the way your immune system works are macrophages go in. When you get COVID vaccine, you get the little COVID vaccine under your arm, macrophage will go by, pick it up, present it to your, either that or another antigen presenting cell, presents to lymphocytes train, blah, blah, blah. The rest is history. But it all starts with macrophages. We don't have good macrophage infiltration. So this was really proof of concept. So we have finished our phase 1 trial. And what do we do now? We're in our phase 2 trial. So now we've went from 10 patients. We're publishing that now, but I already have approval and we're open and enrolling for our phase 2 trial. And sure enough, with that, I decided to go to Omentum and use Omentum for bypassing the blood-brain barrier. And here, in talking to the FDA, I had a rabbit model from 1990. That was my evidence. So you have to learn the history of medicine and science. But this is part of that protocol of convincing the FDA that things are safe. If you put Omentum on the cortex, blood vessels form very quickly. These blood vessels lack a blood-brain barrier. Here's how much Omentum we have. What's cool about Omentum is these things called milky spots. Milky spots have all of these immune cells in them. So basically, I can put this in the human brain and give the patient cell autologous therapy. And that's the rationale. Just to let you know, we do this at Lennox. Look at that. It looks like chicken paillard or something, but it's a massive slab of Omentum. So we have unlimited supplies of Omentum. So from a side effect profile, you're not going to miss some of your Omentum. Whereas if you took lymph nodes, for example, out of a chain in your neck or a chain in your axilla, you get lymphedema, you get side effects. So again, another video, but so we were the first, and this comes back to also how you speak to patients. So all of these patients, I had a first patient for all of these trials, and they all asked me the same question. So how are the rest of your patients doing? And I have to say to them, well, you're going to be the first person who's ever had this in the world. And they say, there's a massive pause usually. And basically I say, you're not the first person to get Omentum. We do a mental cranial transposition for moya moya. You are the first person that's going to get this for glioblastoma. We use pericranial flaps for head and neck cancer all the time. And I show them the literature. But you're going to be the first person that takes this technique and we use it for glioblastoma. You're not the first person to get intraarterial drug delivery for glioblastoma, but you're the first person to get intraarterial drug delivery with this new drug or cetuximab, whatever it is. So again, the whole group, and I train, we sit in our room and we go over the discussion because it starts with the intake of the first phone call that my coordinators get in the back office and how they're talking to patients. It's a very, very interesting and time-consuming, but really important, under-talked about way of building your clinical research portfolio. Everyone's got to learn the language and develop trust with your patients. Here you can see a piece of Omentum. So look at this, before and after. This is Omentum. This is Omentum stuffed into the right temporal lobe of this patient. And here we published this just last year. Really exciting stuff. You can see how big a piece of Omentum I put in this. This is a guy who's rock climbing. So he's rock climbing with a huge piece of Omentum in his brain. left frontal. So again, it's also hard to talk to your patients about, he's a doctor from Austin, Texas, and talk to them about, are you willing to share your stories with other patients? Are you willing to take a picture of yourself rock climbing that we can share on our socials? It actually drives a huge amount of volume. But this goes back to the milky spots. So what the great thing about his brain now is he's got more milky spots in his brain, looking around, searching for tumor-associated antigens, and he's alive 2 years later. But this is what a milky spot looks like. This is actually one of his lymphocytes that's in his brain. You can see now he's got T cells in there, B cells, and a whole host of macrophages and monocytes. The other thing I want to just tell you is also clinical trials span departments. So neuropathology gets their fellows involved and their publications and whatnot. So I can't emphasize that enough. Again, Tamika Wong's name is here over and over again. And it also allows other companies, and this is where I'll close, we've become sort of a mecca. I know there's some industry in the corner there, and thank you for being here representing. But when industry then comes to us and says, hey, we know you're doing some unique things, when Boston Scientific decided to investigate intra-arterial Y90 Therasphere delivery in GBM, they came to me because they said, well, here's someone that's doing this risky stuff. We think this may be a little risky. So they came to me and asked if we would enroll, be a lead site with Northwestern, and we are. So this just opened. They got conditional approval for intra-arterial Y90. Again, giving Y90 intra-arterially for patients with glioblastoma. And again, you guys are used to these endpoints and whatnot. But I'm going to end here. I think these are just a couple of cute slides. Sometimes innovation can be looking at existing treatments in a new light. And actually, that's David Langer with his shoes off as we cross Park Avenue. But this is a great quote. I have no idea what's awaiting me or what will happen when this all ends. For the moment, I know this. There are sick people and they need curing. So that's what motivates us every day. As I told you, and I'll end with this. This is a picture from those dark days. This is what we wore to consent. So besides language barriers that are often an issue, we couldn't hear each other. Patients were ventilated. Can you imagine? And I'm holding a consent form. How possibly, difficult was it to get informed consent? But we did it, and we pushed each other to do it, and it was really an amazing time. This is my basic research lab. Now, the only thing I'm going to end on is this last statement. If you look at all of human disease, patients who participate in clinical trials outperform those who do not in every category. Why is that? Because the placebo effect is real. So even if you get a control and you're in a clinical trial, you're going to benefit because the placebo effect is real and the Hawthorne effect is real. Remember, the Hawthorne effect is observed patients tend to outperform those who aren't being observed. And your nurse practitioner can find more adverse events. Your coordinators find adverse things. So in all human disease, patients in clinical trials outperform those who don't participate in clinical trials, even if they get a placebo. So with that, I want to thank you again, and I'm happy to take any questions.
So how long does the brain barrier with any method that you do last? Because I'm thinking, like, if the person has the momentum for 2 years, it's not preventing other stuff from getting into the brain from the same spot. Plus the momentum or anything else you put in there is also getting vascularized with other normal brain tissue. So it's like, it's hard to wrap my head around that.
Yeah. It's a good question. What's happening 2 years later? So what's interesting, and we only have 4 patients with momentum in their head. One has died a year and a half later. She passed. Interestingly, the area where her omentum is never progressed, but she progressed at a remote site. The doctor from Austin is still alive, and we have 2 patients I recently implanted in our phase 2 trial. But the only person that we have who's a long-term survival is that doctor, and his omentum is actually shrinking, meaning that the body is basically macrophaging in a way slowly, which is even actually better news, meaning that there is this inherent infiltration so his, actually, if you look over time, and we're going to publish this, his omentum is actually shrinking. Now, I don't know what that means. The only two things I know is that he's alive, and that thing, the omentum, which is a massive amount of omentum, is like a third of what it started with. That means there's an active, phagocytic engulfment of this tissue. Now, how that interplays with tumor-associated antigens, I can't possibly know because I haven't done autopsies and we haven't seen it. And we don't, even in moya patients where we put omentum in, we don't have autopsy data. We know that the blood vessels penetrate the human cortex within 12 hours. That's how fast omentum causes blood vessel infiltration in moya patients. Yeah.
Great talk, and more importantly, just fantastic, impressive work, so thank you for that. Lots of good stuff throughout there. Just one little comment. I really appreciated how you highlighted that 33-year-old paper, and how there was something in the literature that you all went back and found. I wish there were more students in the audience today. That's something hopefully we can get for next year. But it's really important for all of us to remember that there's just so much out there we have to dig and look for it. My question relates to, I think at least what I see as our current biggest problem here at Downstate in terms of getting more clinical trials up and running is getting our clinicians to be clinician researchers. And you mentioned that in your department, basically everybody's expected to do so, and if they opt out, they have to make a really good case. I don't fully or even approximately understand the business model of medicine, but I do know that, say, getting protected time costs money. I'm wondering how you got it up and running. Did people have to find additional time, or were you able to something else? So, and with an eye towards how we might be able to port that here.
So first of all, let me talk to you about students. And Hamza, am I allowed to introduce you? Hamza Khilji is one of our fellows. He's a third year now, medical student here, and doing important research in hydrocephalus now. So I actually think it starts at the student level, and I think a clinical research symposium should be mandatory for med students and nursing students and PA students and at every level of clinical coordination, because unless you understand it, you can't teach a full professor who's never done clinical research. We do it, but it's very hard to, teach new tricks at that stage. It's very easy. So the way I did it is I started in medical school and residency, and as an early, you have a lot of time, believe it or not, as a junior attending. And that's really the time where you have to, research RFAs, like requests for, proposals. We have early investigator seed funding. And also you have free time. And I hate people, yes, there are people that complain about, I don't have enough protected time, I don't have enough protected time. I didn't have protected time when I did this, but I found a way to do it. And I knew, there was the chair of neurosurgery at University of Illinois. It's a guy named Fadi Charbel, and he gave me the best advice. He goes, the only horse you ride out of your residency is your research. He goes, nobody cares if you've clipped 100 aneurysms or you've taken out 100 GBMs. The only horse you should ride out of your residency is your research, because that truly is what's going to make you unique. And as junior faculty, I would argue that as an assistant professor, first of all, that's how you get promoted, but they should be encouraged, if not mandated, to look around in cardiology and geriatrics and endocrinology. There's trials, and you have to point somebody, the Yehenus of the world, to identify them and make them do it. Or you're not part of a medical school, or you're not in private practice. Because it's a business model, and for Downstate to be the hub of clinical research for this area is huge. I mean, you got 3.2 million people here, something like that. Yeah.
Jeanette Jacobs from the Department of Dermatology. Thank you for that talk. It was really amazing, and the work that you do is amazing. You mentioned going from an institution with a lot of red tape to one with little red tape, so I was wondering if you could highlight some of the ways your institutions helped you along your path.
So there's still some red tape. So you just have, first of all, as a young investigator, you have to have good mentors in the institution. You're never going to be able to do this unless you identify a mentor that is helping. And we help our gynecology, oncology researchers, thoracic oncology. When I came, cardiology was a very robust and mature clinical research enterprise under Christina Brennan and Yehenu. And knowing that there was some infrastructure was important. Now, if you're in an institution that has zero infrastructure, you have to go to the deans of the world and say, I'm interested as a whatever level you are, and doing these clinical trials. And by the way, it's very helpful when you understand what trial you want to bring. So I'll give you an example of a young investigator at Lenox who wanted to bring phase 1 trials in gynecology oncology. Now, I worked with her and her staff because I knew that was important for her business strategy to get patients. And sure enough, 5 years later, she's booming. She has great trials, phase 1, publishing. She actually has been promoted to run the cancer center at Lenox. Again, this stuff just rolls downhill. Mentorship is key, administrative leadership, and if you're running into roadblocks. So they had no idea how to do, outside of cardiology, any other research at Lenox Hill Hospital when I get there. None, zero. But my mentor was a guy named Kevin Tracy, who now is the president and CEO of the Feinstein Institute. And when I got recruited over from Cornell, I said, Kevin, I'm not coming unless you guarantee in writing that you're going to provide the infrastructure to develop a CRO, a clinical trials office at Lenox Hill Hospital. And so Feinstein Institute became the hub where we sent all of our research, and it was like 90 days IRB. And if I didn't get a 90-day approval, they rejected it on scientific grounds, which I have no problem with. If they said, John, we want you to do, instead of, doing it twice, maybe just do it once before you move on. That's fine. If it was red tape and they couldn't get it reviewed, I wouldn't accept that. You have to push, but you have to have good mentors and you have to have good administration. We were the one thing I can say about Northwell is they have a great administration. Their door is always open, both at the research, but the local level and at the federal level. They have a very good communication with their team, and that's something that's invaluable. On the contrary, when I was out in New York, I had a slide of this. When I got to Lenox, at the Feinstein Institute, there was a door for grants and contracts. The next door was a person who worked in IACUC. The next person was someone that, was IRB. They were all lined up, and I would shake hands, and I knew the person, and they responded to my emails. At Cornell, I would send an email to IACUC, and I was like, I don't know where this is going. I wouldn't get a response. I never met the person. And then, 3 months later, it was a different person, and then grants was a different person. It was a mess. By the way, the clinical trials office at Cornell is still closed, believe it or not, post-COVID. So, which is amazing to me, that you can have an academic medical center, top ranked, has a very, very bare bones clinical trials office. So you're not alone. And I think it's an important thing to recognize. It takes work, it takes infrastructure, it takes organization, but this is where it starts.
Hi, Aller Schultz, MS2. I had a question more specific to your research. I have a particular interest in GBM and the viral vector treatment, but more than that, I'm interested in biomarker changes in recurrent GBM, and I was wondering if you have investigated that and if you'd seen anything interesting.
So the question is, are there changes in biomarkers in recurrent GBM? 100%. In fact, the disease of recurrent GBM is totally different than newly diagnosed GBM. In fact, all of human cancers, once they get treated, you're dealing with a whole different tissue population. Now, some of the genetics, for example, in recurrent breast cancer, stay the same. What's interesting about things like breast cancer is the breast cancer in the breast may have a different genetic biomarker than when it goes to the brain. But for recurrent GBM, in general, they maintain the same genetics at recurrence. The difference is they're radiated and they have what's called desmoplastic changes, but the genetic biomarkers tend to be the same. So if you're IDH wild type and newly diagnosed, you're going to be IDH wild type at recurrence. If you're EGFR amplified, you're going to be EGFR amplified. We don't do enough of that. And that's a good area of research. We don't look at, and the other problem is our patients at recurrence tend to be very sick by that point. So there rarely are really good, healthy patients at recurrence. So the idea of sending panels of like 400 genes and do next-gen sequencing at recurrence is a great project. And it has been done. It just, we haven't found, what percent, I'll ask you a question, not to put you on the spot, but you're a med student. I'm not sure we're allowed to do Socratic methods anymore, but what percent, this is to the group, what percent of human cancers have a targetable mutation that actually we have a drug for? 4%. That's it. So we all have these fancy genetic panels. You know, Mount Sinai's opened up the blah, blah, blah center for, you know, cancer genomics, blah, blah, blah. Every institution has their own impact testing. 4%. That's it. So you're working in the right area. You just have to find the answers. And recurrent GBM is hard because not all the patients get tissue because they're sick. They don't get surgery. The tissue is often radiated, so that provides a huge amount of challenges. So it's interesting. And the viral vectors comes back to the same question of can you get lymphocytes that are trained by your viral vector to get into the brain and eat the brain tumor? We should talk. Anyone else? Well, thank you again. Absolute pleasure.
The next part of our presentation is the clinical trial infrastructure. So the clinical trial infrastructure at Downstate has come a long way, even since I've been here in 2014. We now have a clinical trials division that's part of the Office of Research Administration, and we offer study coordinators for all clinical trials. We've updated our website, so you can see that we have information on our website for patients, investigators, and sponsors. The patient information part of our website hosts all of our studies open to enrollment, and we receive that information from the IRB. The investigators section of our website talks about how we can provide resources for our investigators, all of you, and what those resources are. And then we have a sponsor section of our website, and that's specifically to sponsors, showing the types of studies that we have open and the types of studies we do here at Downstate. So this is an example of the patient website, and when you click on the button, you will have the clinical trial number, you will have the name of the study, the sponsor, and whether it's open to enrollment or not. And we've done it by discipline, right? So it makes it easier for patients in our downstate community to find a study that works for them, that they might be interested in participating in. And then we have other important information about the types of clinical trials, why we have clinical trials, the importance of clinical trials. And again, as I said, the ones open to enrollment. So we're hoping with this new website, our patients will be able to find clinical trials here at Downstate and find all of you as the clinicians.
So, you know, as Sharon said, you know, we're hoping that we are going to be able to encapsulate all of the different areas of clinical research support that you guys can get, as well as our patients and the sponsors. And those tiers, 3 tiers of support that we provide, one to the sponsor, one to the investigators, and one to patient, really are the core of what we try to do our supports in. The investigators section really provides the opportunity for our younger investigators, investigators that are coming new into research, to be able to find us and be able to get that support that they didn't have in the past. We do have a lot of work to do in building the research infrastructure, and the investigator section will provide you with the research pharmacy, in research coordinator support, building budgets and coverage analysis, being able to support in contracts and negotiations as well, and the space that most investigators are always looking for to do their clinical trials. We want to be quite visible for our sponsors as well. We want to have that one hub that all sponsors can go to be able to actually get that clinical trial done in our office. We will do all of the contracts, all of the feasibilities, invoicing for these trials, all of the negotiations that are needed to get that that clinical trial started up. We realized building an infrastructure really starts from the bottom, and really having that support that all clinicians need to be able to do their clinical trials in a most accurate data supported, that being able to support our investigators with the most talented and really equipped clinical research coordinators is important to us. And a lot of the difficulties that we faced in the past has been we have been unable to retain a lot of research coordinators to be competing with the Northwells of it, with the NYUs and with other New York City really rich hospitals that are providing research coordinators. We wanted to be able to be competitive as well. And so one of the things we've started is the RISE program, which allows our coordinators to grow within the downstate space, providing them the ability to actually stay within rather than having to look outside. During COVID, we've lost a lot of people. We've lost a lot of really good clinical research coordinators to sponsors, to CROs. And obviously, we can't compete with the financial compensations that they were providing. So this is an incentive to really address that issue. And it is essential for a lot of us to actually have a well-trained clinical research staff. And when I say staff, I don't mean just coordinators. I think we need to really train our junior physicians as well. And this is what we sort of came up with. We did a 2-session training program that actually addresses all of these different items that you see on this slide. These will be these trainings will be given by other senior research leaders from all CUNY, who will be able to present on these. And we're hoping to get not only our coordinators, but our investigators also to take part in these, be qualified to participate in some of the clinical trials we're bringing on. And we've also identified that it is so important to know what's available and how to get it done. We put together a 60-page handbook on how to build a research infrastructure. We're hoping to implement this out and bring it out into the community and be able to support our investigators. So these are some of the infrastructures that we've been working on in the past. That's a last slide.
So as we pointed out, there's been a lot of changes. One of the things that we've been struggling with is having enough coordinators in our pool to offer every clinician a coordinator as a study is being onboarded. And later this afternoon, we'll talk about the staffing services that we have available for those coordinators and for these, all of you, the clinicians, to be able to support your clinical trials and clinical research. We are working on training, as Yehanu pointed out. We do want to train all of our researchers to be PIs of clinical trials, whether you're sub-investigators, working with a mentor, and we've all discussed the importance of having that mentorship, but we are looking to reach out to medical students and residents and attendings, and we're hoping that they will be participating in clinical trials going forward. Does anybody have any questions about the new infrastructure at Downstate?
Although these are some of the the things that we put up here on the slide, there's a lot of work that was done by senior leadership, by Sharon, and me coming in about a year ago, maybe a little bit more, to sort of change the mindset of a lot of us who have really done clinical research in silos and now trying to bring it to that centralized research administration's office type of model. Some of our fee schedules have completely changed from the way they were to right now. We were not being competitive compared to other sites, other other hospitals that are around us. We did not have the physicians who could have taken on some of the challenging trials that we're currently taking on, and we were starting to see shift in that because of the support that's provided. We've created some systems that would allow patients from being charged or being their insurance being charged when it's a clinical trial. So we have an outpatient registration form that prevents some of that stuff from being done by doing it in the front end rather than coming back later on and after a patient's been charged for their for participation in clinical trial. We've been able to avoid a lot of those really holes that we had in the past. So the office has been doing a lot of work to support a lot of our physicians. I hope some of that has shown within the last year, and we have a lot of work to do to sort of get us where we need to be with the Northwell of New York City's top enrolling sites right now. We certainly are not there, but I think we are heading in the right direction. Any questions?
I think one of the main focuses that we've really focused on during this period of building an infrastructure is being able to work with WCG and negotiate budgets, do cost analysis to make sure that we're not in a deficit upon entering a trial, which is really important, and working with the hospital on those protocols and allowing them to decide which studies might be the most important, right? Studies for them, especially as it turns, for the device trials and the inpatient studies. But having the cost analysis and the budget build really is saving a lot of time that investigators are not dealing with these issues in the middle of a trial. So for patient enrollment and the dollars that we're collecting, for advertising pool, we really want to focus on, getting money from our sponsors for every single study so that we can advertise appropriately. We're looking to do PSAs going forward, and we're going to count on the IRB and our clinicians to do these PSAs. We want to focus with, we want to run the PSAs in our emergency rooms. We want to go out to the community with churches and barbershops and everything else, really getting some buy-in and tie-in with School of Public Health, because this is what they do, right? So I think that as a team approach, we can get these clinical trials out there for everybody in the community to see, so that people are interested in doing the clinical trials and clinical research at Downstate.
One of the things that we've kind of put together and the biggest sort of task that we've taken on at Downstate so far has been the Trinetics. And that is going to be one of the game changers for us, we hope, in being able to bring on new trials into our site and being able to give our investigators access to data. I won't steal any of John's thunder. John is here from Trinetics, who will be talking about that, and hopefully he'll give you guys a really good understanding of what's to come in the coming months.
So hello, everybody. My name is John Esposito from Trinetics. We are based in Cambridge, Massachusetts. I happen to live in Huntington, right out on Long Island. I had a nice hour and 45-minute commute here this morning, which was terrific. It's been a while since I've done that, but wound up in a great place with a lot of friendly faces. Thank you for the invitation to come here and speak with you today. What I'm going to tell you about is one of the things that we hope will positively contribute to the resurgence of the research enterprise here at SUNY Downstate, and that is our technology platform. So I'll tell you the story. Basically, back in 2013, we were actually approached, or our founders were approached by Novartis, of all organizations, and they were looking for a way to solve some of the problems that were vexing them in the process of designing clinical trial protocols, assessing their feasibility, and then delivering those opportunities to healthcare organizations that really did have patients that matched those protocols. Historically, that process has been very manual. It relied on sort of verbal or email communications between the pharma companies and PIs asking for back of the napkin estimates about how many patients they thought they had within their realm that matched a particular protocol. Invariably, those estimates were off. This was causing some of the issues that I described a moment ago, namely that they would have to go back and amend their clinical trial protocols multiple times, adding lots of additional expense and lots of additional time to getting new therapies to market to the patients that need those therapies. And so they were looking for a different way of doing the process of designing a clinical trial, assessing its feasibility, and delivering the opportunities to the healthcare organizations that, based on real data, actually did have patients. And finding nothing out there that could do that, TriNetX was born. They put up some of the original seed capital, a business plan was written, and then in 2014, the company went operational. I joined in December of 2014. I was the 15th employee. When I came into the office, there were 0 customers. And so what we took out to healthcare organizations was, in essence, a PowerPoint and a business proposition. And we said, if we could create this safe ecosystem within which you could share your de-identified data in the interest of identifying yourselves as sites that could actually execute on clinical trials from pharmaceutical companies that were looking for partners, would you come on board? And the answer was resoundingly yes. So TriNetX was born, and the basic point of the platform was to create a research-only global network that would help foster better collaboration between sponsors and healthcare organizations, and at the same time provide a very rich data and analytics asset to the researchers that were looking to do outcomes research and deeper epidemiological research. So, as I think you can surmise, pharmaceutical companies and CROs use this platform to design trials, to assess their feasibility, and then to electronically transmit those opportunities to TriNetX healthcare organization members that have shown up as having patients that match those protocols. Just to give you some concept of how quickly this can be done, we have basically taken a process that might have taken 6 months to a year previously, namely, I, as the pharma company, how do I ascertain whether or not a particular healthcare organization has patients that match a clinical trial protocol? That's phone calls, that's emails, that's every site running its own query against its own research data warehouse or electronic health record. They can do that in 10 seconds now. So TriNetX has an online, on-demand, highly performant, highly scalable network that allows a pharmaceutical company to put in a series of inclusion and exclusion criteria into our platform, push a button, and then see, in essence, rounded counts, okay, of patients that exist that match those protocols at each of our participating sites. And one step further, deliver the opportunity. Would you like to participate in the clinical trial? The typical TriNetX healthcare organization member receives 4 to 8 clinical trial opportunities a month through the platform from our sponsor partners, okay? This is a completely de-identified infrastructure, so pharmaceutical companies cannot run queries against individual healthcare organizations. The only thing they can see about an individual healthcare organization is a rounded count. They can't look at any of the clinical characteristics of the cohort, only can look in aggregate. So that's the first piece. I will also say, and I'll show you this momentarily, that about 80% of the top pharma companies are on this platform, okay? And most of the top CROs, okay? The other asset you're going to be getting, which was talked about a little bit earlier, was providing data to researchers so that they could publish. So the TriNetX platform will provide your researchers with 2 primary data assets. One is the ability to look at downstate only data. And by the way, only downstate researchers can look at downstate only data. The other is going to be an aggregated, anonymized network that allows downstate investigators to look at a network of over 100 million patients, which is where it's at right now. So as far as publishing power is concerned, the fact that this data is available combined with an on-platform analytics suite and the ability to use third-party analytics packages against that data is going to cut down massive amounts of pain and agony that investigators typically face when they're trying to wrangle the data themselves and figure out how to use a complex statistical package. We have, just so to give you additional comfort, there are over 250 healthcare organizations in 30 countries around the world that are under contract with Trinetics right now. We have delivered what we have promised to the healthcare organizations that have come on board with us. And we have built up a massive bank of an asset called trust, which Dr. Bukvar actually talked about a little bit earlier, and I thought was a very key point that he made during his presentation. Hundreds of papers have been published by PIs, fellows, residents, med school students. You have access to an unlimited number of users on this platform, so anybody that wants access to it that you deem worthy of providing that access to, you can do that. We've also developed a medical school curriculum on biomedical informatics in conjunction with University of Texas Medical Branch in Galveston, Texas, so that if you actually want to infuse Trinetics into the curriculum of your med school students to teach them about big data and analytics and research informatics and things along those lines, UTMB has agreed to share their course curriculum, and we will actually come in and help you implement it. We know how to ingest data from every upstream source, although the downstate data has been a bit of a challenge, okay? We're working hard to kind of get that across the finish line right now. This is a very conservatively governed platform. It's research only, and the terms of use for the data are very, very tight and strict from a contractual perspective. Everything that we do from a de-identification perspective is evaluated and blessed by Dr. Brad Malin from Vanderbilt University, who is arguably the #1 privacy expert in the country. We signed our agreement with you last year. We're coming close to the finish line now when we can get this actually into the hands of your people. So again, as far as functionality is concerned, a sort of cohort identification, cohort analysis feasibility tool for you to use internally, a platform that will provide you with a seamless way of integrating with the other SUNYs around the state via our collaborative network capability, and provide you with additional sponsored trial opportunities from our industry sponsors. The big data platform I mentioned before, over 100 million patients at your fingertips, along with an onboard, easy-to-use push-button analytics suite, combined with the ability for researchers to get raw, anonymized row-level data for use with third-party statistical packages. I'll skip through that. And so here's some of the sort of onboard analytics capabilities that are in the platform. So the idea is that you don't have to be, a statistician to access the platform and get use out of it. This is a list of our US customers, or a partial list. So you can see that you're in that middle column there, third from the bottom. And then here's the remainder. We also have healthcare organizations in Latin America, Asia Pacific, and EMEA, so Europe, Middle East, Africa. About 250 in total. CTSA sites, I know Stony Brook's going after a CTSA grant from the NIH. We have 36 CTSA sites also on the Trinetics platform. We write letters of support for, and Trinetics is a well-known entity to the CTSA. Okay, so they know who we are, and you can use that as an asset to describe your commitment to research generally, and we'll back that up with a letter of support. We have lots of standalone pediatric sites, and then just to kind of give you an idea of how sort of in use this is, between 20 and 40,000 queries a month are run by North American healthcare organizations on our platform, okay? And you're gonna add a whole bunch to that when you go live as well. And as I mentioned before, typically between 4 and 8 trial opportunities will come your way. You are not obligated to accept any of them, but we do want you to accept the ones that fit for you, because it's that sort of positive interaction between the healthcare organizations and the industry partners that makes this network very, very vibrant. My colleague Chris Lugo will be working with you to make sure that all of those interactions are happening seamlessly and that will knock down any issues that we see along the way. This is a partial list of some of the industry participants. Not all of them let us use their logos, but this is a partial list. Give you an idea of the kinds of industry members that will deliver sponsored trial opportunities to you, okay? As you can see, there's lots of big pharma on there, but we also have most of the large CROs, and we're really increasing in the small to medium-sized pharma companies as well. Vertex is a good example of that, rare disease company. What is the data in Trinetics? The data in Trinetics is typically coming out of the electronic health record. It's demographics, diagnoses, procedures, meds, labs, and vital signs. But we also make it very easy to add non-EHR data into the platform to provide researchers with a richer environment within which to do their research. So we can bring things like the tumor stage and other cancer-specific data in from the tumor registry data. We can bring genes and variants in from third-party testing, lab files, and things along those lines. So we have ways of enriching the data to make it more useful to researchers. That's something that Chris will drive with you as the project goes along, is would you like to explore opportunities to bring X, Y, and Z data into the platform? We also have the ability to bring data from unstructured sources, notes and reports into the platform as well. So data that's buried in textual type documents. We target specific, primarily cardiology and oncology facts out of those notes and reports, bring them in as structured data into the platform. Now you can use them in defining cohorts. We also put your data through a rigorous data quality assessment to make sure that the data on the platform is of publication grade. So we're looking for gaps, misfires, things that are out of the ordinary compared to the network as a whole. We'll bring those back to you. We'll help you ferret out the root cause. The idea being that we want a very high quality data network that researchers can trust that when they publish will stand up to the scrutiny of questions being asked of them. And then everything's protected. I'm not going to go into too much detail here, but we have a variety of technical contractual and operational protections in the platform that ensure the number one idea, and that is that healthcare organizations upon whose shoulders this whole thing is built feel comfortable participating in the initiative. And here's Dr. Malin from Vanderbilt. Last slide, just a little bit about how the publications have spiked with the use of Trinetics. We're sort of new kids on the block. This platform went live on January 1st, 2016. You can see the growth in the publications coming out via the Trinetics platform. Again, you'll add to that, but that is a significant asset that I think will be attractive across the board here at Downstate. And that's it. Questions?
Thank you for that. I'm very bullish on Trinetics and what it can bring to Downstate. Thanks for coming here and meeting with us. Just for our downstate community, I think we first, or at least I first learned of Trinetics. I'm sure Sharon was already aware. This predated me and Eugenio. From my counterpart at SUNY Upstate, Dave Amberg, as well as Scott Shurtleff, who is, for those of you who don't know, he's high up in the Research Foundation Central in Albany and is very involved in clinical all research, but really pushing clinical research. But Dave Amberg and I spoke about it a couple of times, and it really became clear that one of the points that, for those of you here, were here at the very beginning of the morning, when I mentioned that we're really striving to expand and grow Downstate's attractiveness for clinical trials to external entities, and one of the ways that we're doing that is by putting ourselves in a position where we can make a credible argument that if they work with us, they actually have access to an even larger patient population. There's, of course, Maimonides in Kings County, a ton of work going on to try to smooth and build partnerships and agreements. And then there's SUNY broadly, and I mentioned Upstate. And so Trinetics is something that made it quite clear that they're in Trinetics. If we also get in, there's Stony Brook, we really can make an argument that not only pharma company X do you get access to Downstate's underrepresented population, which we know you want, but at the same time with some other agreements, without having to do a lot more work, we can bring in, say, SUNY Upstate and Stony Brook. So anyway, that's not a question, it's a comment, but I just wanted to provide that context for our community here as to one of the reasons we've engaged with Trinetics and have the contract.
I appreciate that. I mean, and just to make it clear, we definitely prefer positive comments to tough questions, so thank you for that. But that is great. And you forgot Buffalo, too, because Buffalo's on the platform as well. So we have to work on the School of Ophthalmology, and that's the one that we haven't been able to quite bring on board yet, but all the others are there, yes.
Buffalo often seems to forget us, so it's a little bit of payback.
Maybe clarify for us some of your, if you're doing anything with AI and using AI to develop algorithms and protocols for particular kinds of questions, or is it all going to be individual researchers coming and starting from scratch for their projects, or is there AI availability within your system?
So right now, AI is not like a factor in the Trinetics platform, and the thing that is that I want to just say is that we are always balancing privacy, security, and governance concerns with functionality, okay? And when Trinetics makes a decision where one of those things weighs against the other, the decision always comes down on privacy, security, and governance first. Now, if there are opportunities to leverage those new technologies while preserving our conservative stance on privacy, security, and governance, yes, we'll look at those. We are obviously a disruptive technology company that has created new ways of doing things, and that's been our whole existence. We want to maintain that, but just in a prudent and conservative way.
Thanks. And one other follow-up, just more granular. Are you collecting detailed information off radiology reports as well, or is it
Not
only
yet.
summary data from discharges or clinic notes and things?
Right, summary data so far, yeah. The imaging data, not yet.
Thank you, John. You know, Trinetics has been long coming, so we're excited to see it come to fruition. In speaking about expanding your clinical research and bringing in new investigators into the pool, I'm excited to bring you guys now Dr. Wallach, who is our newer investigator who's doing some great work at Downstate. Please welcome Dr. Wallach.
Thanks everybody for having me this morning. So my name is Tom Wallach. I'm a pediatric gastroenterologist and a translational scientist, and I am somehow, there we go, I figured this out. and I'll be talking today about sort of what it's like to do clinical trials here at Downstate and sort of the main reasons why I think everybody should do that and why we should all be interested in it, because I think there are a lot of structural meta-society reasons why we need to be doing clinical trials here, and then also individual things that benefit us and the institution. So it's a win-win for everybody for us to be doing more of this work. I do have some disclosures to note. I do speak for Nutricia, which is a formula company. I'm an advisor for Kiwi Biosciences, which is I am clicking through stuff too fast, which is a IBS therapeutic company, and I'm the PI currently for Ardelyx Pharmaceuticals' tenapanor trial. So forgive the flickering back and forth, but today we're going to talk about disparities in clinical trials and sort of why I think it's important that it's particularly at Downstate we do this work. We're going to talk about clinical trial environment at Downstate and all the resources that exist here that you may or may not know about. And I'm going to talk about my practical experiences with the trials I've done here. So clinical trials, most people will probably know what is entailed here, but the main reason why we do this is to find out what works. And from an industry perspective, it's to support that it works so they can get FDA approval and get specific indications, which allows them to put pressure on insurance companies and other payers to support the use of treatments, novel technologies, or novel approaches. And so there's both a discovery need and a regulatory need when you're talking about a trial. And there's a lot of work that goes into that and things that go into it. And I included this graphic of all the different steps from getting a drug from discovery to distribution. And it is an exhausting and rigorous process that takes quite a long time. There's also differences in how you do clinical trials, because clinical trials can range from really small things like I've done here to large multi-center trials, which I've also done here. And it is something that is available both unfunded, funded, from an NIH-supported perspective, from an industry-supported perspective, or from a larger scale, federal, institutionally supported multi-center. So there's a lot of different ways that these projects can occur. But it's useful for us to do them for reasons I'll get into. The biggest reason why I think Downstate in particular has a responsibility to do more of these trials is because we have a major generalizability problem in research. And we've been aware of this since the late 90s, and it's been discussed since the late 90s, and a lot of efforts have been undertaken to try to fix this. I guess I'm still not sure what's clicking this forward for me, but a lot of studies have been undertaken to try to fix this, and we've made a lot of progress in this. In particular, enrollment of African-American patients or patients of African descent in clinical trials in the United States has gone from almost non-existent to being just deficient. And it's been something that we have worked on and gotten a lot of results. A big example of this is for decades, until the mid-90s, the institutes wouldn't fund and ethical bodies wouldn't allow research into reproductive age women that specifically addressed what problems that only reproductive age women had. And so that's why we are so far behind on things like, various different problems like abdominal pain associated with menstruation or endometriosis. These diseases haven't been able to be studied because they were purposefully excluded. And this is an active version of what is a thing that has happened in many ways that structural issues and societal issues have also created in other groups like low socioeconomic status or minoritized patients. And this creates a research value problem, and I did a bad job with my slide design. But that molecule over there is warfarin, and what is a really good example of this is also that we assessed warfarin in studies in the 50s that looked at this almost entirely in Caucasian patients. Turns out there's a couple different variations genetically that alter your warfarin metabolism, and if you look at patients who are African descent or patients of Asian descent, they're going to have different needs, and the mean dose that you should pick to start should be different for all those patients. And if you looked at this broadly in a bigger capacity, you'd have figured that out. But because those patients weren't included in the trial, we don't know that. And it took us 50 years, basically, to figure this out. And it was only in 2013 that we really identified the various genes associated with this, and that we identified genes before that. 2013 is when we actually made the changes to guidance that we use genetic guidance to start warfarin and to use that on people. And now we have new blood thinners, and it's maybe not the same issue, but this has a huge cost. We know there are huge costs in the United States with healthcare disparities. We know that there is a huge issue in terms of different outcomes. And a big part of this is actually driven by our research issue. And a federal group looked at this, and they actually did a bunch of economic modeling to anticipate if you make improvements in research disparities, you make improvements in enrollment in trials, how much of an impact can we expect that to have on public health and disparities? And they went through a bunch of different things, and that's an economic modeling effort, so not exactly rigorous observed reality. But what we can really reliably say is even a 1% improvement in research disparity would likely generate over $100 billion of gains in just 2 specific disease domains. And so we're talking about huge potential value, not only in terms of our economic cost of healthcare, but all that economic cost of healthcare is actually reflecting really disability-adjusted life year changes. We're talking about people whose lives will be better if we do research better. And a key part of that is we need to do research that involves the people we are going to treat, which includes everybody and not just people who look like me. We have a few more problems with this. A lot of people have sort of said culturally, we can't recruit these patients. They don't necessarily want to. There's a cultural bias against this. And while the legacy of unethical medical experimentation remains big and the trust issues are real, that's probably not the major issue driving poor enrollment in certain and low socioeconomic status and minoritized patient communities. It is really a variety of different things, but a lot of it is structural. A big part of this is access issues. If the place that's running the trial is Yale, the place that's running the trial is Boston Children's, you're not talking about the same patient communities that we have here at Downstate. And so you're not getting exposed to these trials because your doctors aren't suggesting, hey, you should participate in this trial. You're not getting recruited to this trial, and you maybe have a hard time getting to the trial because you maybe can't get to San Francisco from Oakland, or you can't get to Palo Alto from Richmond in the North Bay. There's a lot of reasons why this is hard to do, and it is a big strain. And then there is a trust issue. People get recruited better by providers they know. If you are being sent to some other institution by your specialist to see that person about this trial, how much are you going to say this person has my best interest in mind versus this person's being paid to do a trial? And you do need to trust the person doing the trial because that is important. They're asking you to take a risk. It may be a small risk, but it's still a risk. And you need to know that they have your best interests in heart, and that does require a personal relationship to a degree. And we have those relationships with our patients. Willingness and capacity, willingness is not a great term. Capacity is probably a better term for this. But if you are a low socioeconomic status and you're working 3 jobs, when are you going to have time to come in and do a full day of scans, of nonsense, of endoscopy, or whatever else it takes in this trial? Are you going to be able to make it to those clinic visits? Are you going to be able to do that? There's been a major adjustment in modern clinical trials where people are trying, especially post-COVID, where people are incorporating more telehealth visits and satellite visits to get you more accessibility to patients who don't have the ability to get here. But especially in places like New York, for instance, can you afford to take a car here from East New York? Can you afford to take a car to Columbia? Because that might be what it takes to get there on time and get back to your job. And the thing is, Downstate is here. We are in Brooklyn. We are where the patients we want to recruit live. And we are accessible on the subway to a great degree. We're accessible on bus lines, and people can get here, and they have their transportation networks. And if we don't deliver clinical trial opportunities in places where people we want to be involved live, we will not be able to recruit them because we are asking for too much, and we cannot provide inducements to the degree that would support that because we run into ethical issues of, are we paying you to take this risk? What are we doing here ethically? And so it's important to have those sites locally and have those sites in places where we want those patients. And then the flip side of this is institutional, and especially because so many of these programs are run by CROs or clinical research organizations, low socioeconomic status patients are harder to work with in trials. And it is not because they want to be or because they are difficult or because of anything about them. It's because of institutional and structural issues. If you have patients who cannot get child care cover for their patients, people who lose access to their phone and have to change different phone numbers, people who are moving different living situations, you lose contact with those patients. They have challenges getting to your trial. They have challenges to do this. And they tend to wash out at a higher rate. And that is a real issue and one that needs to be addressed. And one that Downstate, again, is able to accommodate and able to work with because we do have the ability to be flexible and we are easier to get to. Just purely location matters a ton when we're talking about this if we want patients that we need to be in this work to make sure we're doing it correctly to be in this work. The nice part about all of those things is that's also why, as Dr. Christine mentioned, industry wants to work with us because they are being asked by federal regulators to provide useful, meaningful, and generalizable data in their trials. And they have a hard time getting that when they're working with other institutions who don't care for those patients. So we are a solution. And I think for all the reasons that I've said a bunch of these things already, but we are an institution that is based in this community. We are an institution that has a long history with this community. And we are an institution that I think has garnered a lot of trust in many ways. And we have the opportunity to take advantage of that to benefit our community at a meta level, not just a direct patient care level. And I think that's really important and really necessary. And I encourage anybody who has the capacity to consider being a PI for one of these trials to take a look at it, because otherwise you'll see those results and then you'll look at the demographics table and you'll be disappointed again. So now to talk about what it actually is like to do this here. I've done 3 trials here. We have 2 more that I'm looking at that are more grants than sponsored projects. We did one investigator-initiated study, which was I mentored one of my fellows in doing a study looking at use of ondansetron as part of GI bowel prep. This was small. We did 40 patients. It was a pilot study. And one of the big things about this, it was published in part because we are looking at a community that doesn't ever get studied, especially in pediatrics, where the disparities in adults have gotten a little bit better in terms of enrollment. In pediatric trials, it is very, very monochromatic in terms of who gets studied. And so we looked at a community that was not the same community you see in every trial and looked at this and found a benefit for using ondansetron. And it's a pilot study. It's not comprehensive. It needs more work, and we need a bigger study. But we can at least show that for people who prep and these procedures have a much higher cost, because if you can't do your colonoscopy and you took the day off work and you have to do it again another time, that's 2 days of parents taking off of work additionally into what they did. That is a huge economic cost to people who don't make a lot of money. And so if we can add some value there, we've done that. And we did this basically for free and with a lot of support from the institution. And it worked out great. We've also done 2 sponsored trials, one in IBD, one ongoing in IBS. There's also a lot of institutional support, which I'll get into in a second for that. But I think it's useful to describe what it looks like to be a PI. So being a PI, you think, oh, this is going to be a ton of individual work. And in reality, it's not actually a ton of individual work, depending on kind of the infrastructure and team around you. Your main job is you need to ensure that you're being compliant in your recruitment and in your implementation. So you review a chart and say, yes, this looks like this meets the criteria. You are monitoring and reporting for adverse events. So that's monitoring your patients, as well as you'll get reports from the sponsor that say, we've had these adverse events, watch out for this. You are going to read weekly updates about the study. You'll have sub-PIs typically who work with you, or other faculty in your division who will help you recruit individuals, and they will also benefit from this, as I'll get into a little later. And then you will have things like you'll be advertising to other sites. So I send letters out to my colleagues at Maimonides, at Brooklyn Hospital, at NYU, saying, hey, we're doing this trial. If you have any patients you think might be eligible, please come by. That sounds like a lot of things, but in aggregate, I spend probably less than a week on being a PI of a trial, less than an hour a week on being a PI of the trial. It's not a ton of work, and a lot of the work, individual things, the things that seem like a lot of paperwork, are being done by the team here. They're being done by the Research Foundation team for sponsored trials. They're being done by my clinical research coordinator, Cassandra Charles, who's outstanding. And there are people who are efficient and used to doing these things who will take care of a lot of those things for you. And your job is just to maintain the fidelity and the accuracy of it. So you're there to say, yes, this is correct. Yes, this is clinically valid. Yes, we are doing this according to what is supposed to be done. You also get opportunities to push back. In the Ardelyx trial right now, I have worked a lot with the design team to change some of the screening criteria to expand it, because they adapted criteria from an adult trial that don't work as well in pediatrics, and they didn't necessarily adjust that. So you get to participate in the research design itself to some degree. It's a little bit hard to change a trial while it's ongoing, but you can do some things. The Research Foundation team here is great. They have added a bunch of staff members to sponsored projects team, as well as other roles. It has been, in the 3 years since I've been here, night and day difference in terms of what they can do and what they have the capacity to do. They were always working hard, but now they just have more bodies and more resources they can put into the problems. They have multiple employed clinical research coordinators who are available to funded studies or sponsored trials. If you are expanding out to a certain point, you can basically, essentially, have one of those people work with you full time if you're doing a lot of that work. I don't know if anyone here is necessarily there. I'm not yet, but Cassandra Charles, who I work with, is fantastic and a huge benefit to me and my career in both the clinical and sponsored trials that we're doing, as well as other ones that, other work that I've got ongoing, because she's interested in research and she likes to do this work. We have the Clinical and Translational Science Center on the 5th floor, which is a great space for clinic visits. If you're worried about where am I going to do this, there's a lot of opportunities to use that as well. There's a research pharmacy here. We have all the tools you need to do these trials, both as a sponsored project from industry and as an individual grantee if you're looking for support from the institutes. And then what do you get out of doing this? Well, if you do these sponsored projects, nobody's paying you directly, but they are paying the institution, they are paying your department. And the value of that for you is that means that you can use that money to do future research of your own in the future, buy your self-protected time, do other things to expand resources in your department. So there is a benefit to our ability to deliver future research and future patient care from doing this. It is not just you doing it out of charity or because you want to, although, in my opinion, those would still be good reasons. So this was the bowel prep trial. I'm just kind of running through what we did and my experience doing it. As I mentioned before, the fact that this was publishable because it was a pilot is very much because we were looking at this patient community. It's because we were talking about a group that does not get looked at, and because we were adding to the literature to support people who need these sort of incremental benefits the most, because they have the hardest burdens and highest financial cost of accessing care. We did a trial with Janssen looking at a novel IBD therapeutic. This one ended up closing pretty much right after we opened, which was just an artifact of, I think, their poor planning, not necessarily our issues. But it was a little bit of a challenge because of the adult age range for me to be the PI of, and a little bit of a challenge because what I needed to do ahead of that was to work a little bit more with the adult GI division and make sure that we had a recruitment plan on board, because we didn't end up having a very big window to recruit. And if I had like a bunch of people ready to go up front, I would have been able to more rapidly get that out and probably get more people enrolled into the trial from our end, especially because, as it turns out, adult GI keeps most of the IBD across the street, which made for a little bit of a discussion. But a lot of these things could have been done ahead of time, and it was an opportunity to learn some lessons. And the ongoing trial we have right now is with Ardelyx. So here's a picture from the NASPGHAN conference where I presented some of the ongoing stuff that we're doing for them. It's an IBS therapeutic. It's a laxative with some barrier effects. And they have been approved for adults, and they're doing the pediatric trial, which I always love because not everyone pays for the pediatric trial, which is another way in which health disparities can manifest, this one between anyone under the age of 18 and anybody over. This has been done, I think, a lot. We've been doing a lot better with this than the first one I was the PI of, which was mostly about my learning and being able to hit the ground running. We put a lot more advanced work into recruiting from other sites. So I've got contacts out to every pediatric GI department in the city. We've got people coming in and being referred for screening for a lot. They have a little bit of an issue in the very, very aggressive screening criteria, which is not consistent with the way IBS-C works in children. And so we have been discussing ways to kind of expand that, and they're actually going to add essentially another arm probably eventually with a less stringent screen to get into that. But we've still been able to screen more patients, and from what they are telling me, I don't have raw numbers on this, I believe we have screened more patients of color than the entire rest of the study combined. And so we are talking about enrolling the patients that we want to see into this, and that's the big difference that Downstate is able to give you. There are not very many sites that have the majority of their DGBI practice is African American. I actually can't think of another site in the whole country that is going to have that. And that's my area of practice, and I will say that's the bulk of my patients in terms of that. And so how does this benefit you? And again, I did a bad job with my screen size. I apologize. Again, you get funding from this for your future work. So if you are trying to build up more of a research career and allocate more of your time to research, this time could be used to support your salary. It could be used to support future projects. It depends how your department chair and division chief want to use it, but it's still there, and it's really accessible, and it's money that's being paid for your use, if not to you. You get access to the SUNY resources for sponsored and investigator-initiated projects. This has ancillary benefits in a variety of ways because the CRCs, they know how all the sausage gets made. They know where to find everything in this institution. They know where everything is. They know who to talk to. And that is a bridge to get all sorts of things done, even for not your specific sponsored project, because they are wonderful people and they like this work. You get access for your patients to cutting-edge therapeutics. So this means that I can get my teenage IBS patients a pill to help their IBS instead of taking Miralax, which is the main thing that everyone's going to take, and improve their experience of this and improve compliance, because people do better with pills than they do with Miralax. So there is better outcomes and better options here. We get publication and presentation opportunities, especially the more you work with the sponsor, the more likely it is that you'll be able to do things like present for Ardelyx at NASPGHAN or be an author on the paper when it comes out. And these are things that advance your career and your visibility in the field. You don't have to do your own statistics, which I personally find very desirable because I'm really bad at it. But they have biostatisticians, other teams that work with you and handle all these problems. So you get the experience of doing research and the value of doing research and the personal satisfaction, in my opinion, of being involved in research without having to do the part that you hate by deciding, is this really the time to do an ANOVA or do I need something else here? And then almost always being wrong. And then really the most important thing, and the reason why I think everybody should do this and why I do this to a great degree, is to contribute to a democratized and effective future of clinical practice, because it is really shocking how many things do end up having differences and how many are either disguised as being race when they're socioeconomic status, or disguised as being socioeconomic status when it's a genetic difference, right? Everyone thought warfarin issues in African American patients was because they weren't taking it. For decades, that was what people wrote. And it's not. It's because they have a genetic polymorphism that makes them require a higher dose. And that is something that is shocking to me and is so prevalent in so many decades of work that we build our clinical practice off of still. The work all done before the year 2000, for the most part, has huge issues in this, and we still build so many things off that. And it needs to be done in a better way in the future to allow us to do better to all our patients. And it's not just, it reflects back to the dominant group as well. The represented group is not getting the ideal results because there are going to be variations that come out. We don't necessarily understand the pathology as well because we don't look at it in everybody that has it. And that's it.
Hello. Not really a question, but no, my name is Bryce. I work across the street at Kings County, and diversity in clinical trials and retention and recruitment of diverse patients has been a huge buzzword in the clinical research community, or I would say over the past 2 years, all the conferences. And I just really want to say that I fully support and want to say this is a great thing. It's a great job because the questions and all those talks are always, well, how do we get those diverse patients to come to us? How do we reach out and get to those different communities? And my argument has always been, you don't bring them to you. You bring the research to them. The diverse communities are the ones, like you said, they go to the doctors that they trust. So instead of trying to figure out how to take them out of home and bring it to them. So this is great work to really get down to the grindstone and bring the research here to the communities that need it in Central Brooklyn.
Absolutely.
Okay, Dr. Brown, I am coming.
Hi, thanks for that great talk. I've been a clinical researcher here for over 30 years, and so I've done a lot of clinical trials. And I agree with that list of what a PI should do, but I would like to add one thing to that, and that is the PI has to be the face of that clinical trial. Your patient does not look at you as a PI. They look at you as the doctor. And so that you have to show up to do the physical exams and the visits. And so that's very important. And once you do that, then you create trust. And guess what? That patient will go out and recruit another patient for you. So it's important that the PI show up, physically show up and be on site and not just delegate everything else to the clinical coordinator.
I totally agree. And, I think the way that manifests in terms of our current trial is, the other sub-PIs that are working with me are also pediatric gastroenterologists, and we come up and interview and examine our own patients when we recruit them in. And so we do try really hard to maintain that relationship, and it is necessary for the trust perspective, for them to feel taken care of, because that is what we're trying to do. I think that's totally necessary and a great point.
Marcus, hold on.
Dr. Wallach, thanks so much. Excellent talk. From your perspective, how do we create, you've mentioned sub-PIs, how do we create this pipeline of, junior investigators who become the next generation of, clinical trialists or leading?
I think that there is a lot of interest in younger physicians in having this and having more hybrid careers, and especially as the traditional research pathway has gotten to be more and more the equivalent of becoming successful in movies or as a musician, where you have to get lucky and the NIH pay lines are moving every year and everything can be a little bit intense, and it's a little bit about who you know and where you are. One of the big things that we have emphasized in recruitment for PGI is that we have the opportunity to do research and we have the community in which we need to do research. And there are a lot of physicians and a lot of scientists out there who want those opportunities. And a big part of it is expanding back out, I think, to some degree, our clinical services and hiring more people. But a lot of what to do ongoing is to really emphasize how much of this is there. I think that we had some periods of less robust external research infrastructure that led a lot of people to believe if they were going to do this, they would be taking on a whole bunch of work that would be maybe daunting with a full clinical schedule. And I don't think everybody, especially folks who have been here for decades, necessarily knows how much that's changed in the last few years, with the addition of some of the people sitting in front of me. And that it has been a very different ballpark, because I remember starting here 3 years ago and people being like, it's going to be really hard, and I have not found that to be my experience. I have found the RF to be extremely responsive and fairly agile, despite suffering from what most everyone here at Downstate suffers from, which is not enough people to do all the jobs. And I think that the awareness of that and the awareness of the benefits of being a PI in these trials and what you can get out of it in terms of institutional support will do quite a lot, especially with the early career faculty that come here, because I think we do have a nice situation to support people who can have enough time, who can have that 20% to really handle this, or honestly even 10% for some trials, depending what you're talking about. And I think it's very doable, and it's really just an awareness issue, and it's to some extent a cultural issue that we can correct by just pointing out how easy it is. And I think doing things like this symposium are one of the first steps to doing that, and advertising how we've brought in the two of you in many ways is also really helpful to kind of lead those efforts.
Thank you, Dr. Wallach. Oh.
Dr. Wallach, Dr. Lambert kind of took my question, but I have another. I'm surprised to see, I know we're trying to make a lot of efforts into getting the clinical trial out into the community so the community knows that it exists. One of the challenges that I have actually noticed is some of our physicians within the hospital don't know that the clinical trial also exists. So how do we get that word out within the community of Downstate, physician-to-physician engagement, or knowing that treatment or care option is available for the patients that they treat here?
So I think if there's not like an individual driver who seeks these opportunities out, and it was something I was interested in, so for me it was something I kind of sought out on my own. When we have trial opportunities, I think it's really useful to go directly to a chair and a chief and say, hey, these people are interested in a trial. Do you have someone who you think might have an interest in developing a research career and working in this, and we can help carve out some time, and here are the resources we can offer you. I think you have to go to people directly. I do not think people read mass emails, and I can say that both from personal experience and also from just literature on mass emails. Like, nobody tends to read those things. So you can send out something saying to everyone, hey, we have an interest in this, but nobody's going to chime in. You need to kind of go to the individual people, and it needs to be something that the individual chairs and chiefs are motivated to do. And some of our departments and divisions are very focused on getting research done and getting things done, internal medicine, pediatrics. I don't know everybody else from everywhere else, and some are not as focused on that, and some are a little bit more focused on clinical care and providing direct service. And if it's made an institutional priority, especially from the College of Medicine, it is really helpful. And if we're able to, I think, encourage the hospital side and to point out to the hospital administration how these services benefit them in terms of direct payment for different services, direct opportunities, expanded access, and improved credibility, that will help a lot in kind of expanding these things. We need it to be something that there is incentive from both the College of Medicine and the hospital to do. And right now there's a lot of incentive from the College of Medicine, but the hospital is in some ways makes it sometimes challenging to have access to resources or access to tools. It's not that they're doing that on purpose, I think. It's just that our hospital has many budgetary issues, as we all know, and sometimes that leads to challenges in interfacing certain tools or access to certain aspects of things in the OR. This has come up for me in terms of getting the people to talk to about having video endoscopy capacity. Like, we have it, it exists, but finding the person who could help me set that up and help me connect it to the Janssen program was more challenging than I might expect. And those hurdles can add up for someone who's less motivated. And so I think a big part will be trying to figure out how to work better between the multiple parts of our institution, which are not always having the same interest.
Great talk. I'm glad that Marcus and Eugenio made these comments as well. I think so far today, I can say that I'm extremely happy with the day and everything that everybody's done, presentations. But the one frustration I have, which I noticed basically at 8:50, was looking around the room. I'm so excited to see there's a lot of leaders here. There's a lot of administrative teams here, but there's very few clinicians. And that was our target audience. So we've already started to have conversations in our team. It's like, okay, what do we need to do around awareness? And I think we can think about how we can change that for next year when we. But in the meantime, I think one thing that comes to mind based on something you said and a conversation I had with Dr. Bukvar, we got to take our show on the road. Got to go to department meetings and bring it to them because otherwise. And with your permission, I'd like to use one of your slides, a photo of you and the slide praising the RF because we don't get much of that.
I think that, knowing the history of the institution and kind of what changed in the varied nature of state support for us and the nature of the difference between the funding environment in the 90s when HIV was getting a lot of resources and we were a leader in that to what happened in the aughts when they started stripping NIH funding. And we, as did many institutions that take care of low-income and minoritized patients, lost out in a lot of these deals and they went to I did my fellowship at UCSF. I love the place, but it is very, very well funded and very much taking care of one set of people. And I think the problem is that because we've had sort of a while where we had challenges with that, where we were losing ground, that the regaining of ground in the last few years has become hard to see because a lot of the people who we wanted, who have been doing clinical trials for 30 years, who established themselves when we were doing really great things all the time, have retired or moved on, and the people who are left are mainly clinical. And there's nothing wrong with that. We need clinical providers and strong clinical providers, and I think the service we provide to Brooklyn is deeply important. But they are not used to looking that way, and they didn't necessarily come here with that in mind. And I think if the divisions and departments are aware of what they get out of this, if there is carrots to go with that, where not only do the providers find out what they get, but the divisions and departments find out they will get some funding from this, and the College of Medicine encourages this and supports this by providing more resources or support to divisions and departments that are producing academically and participating in these roles, I think that we can see a change in that. But right now you have division and department chairs that are struggling in a tight budgetary environment, and it's hard to find people that they can allocate research time to. And if you're not used to the idea that you're going to do research, it does sort of seem like a departure, because especially in a modern training environment, they really do cohort you towards certain things. And if you don't think you're going to do research, or if you don't consider that a possibility, you often don't develop a lot of the skills that you need to do it. And so the idea that you're going to jump into it seems maybe challenging. And I don't think that there aren't people here who would do it. There are a lot. And there are a lot across the street. And I think if we're able to get a master research agreement done at some point, which I know you all are working on, that will be huge and make it much easier for us to do these things. I think if you look at the two institutions as a whole in aggregate, and you look at some of our academic affiliations with Maimonides and with other places in Brooklyn, we have the bodies to do these things. What we don't do, I think, is we have the departmental and institutional, lower level support to push people into that and to incentivize it. And that, I think, is the big gap. Not everyone is trying to become, a rock star researcher and hope that works out in their career, because it is a hard path and it is a painful path. I have so many grant rejections, Sharon can tell you. She's probably mad at me. But I've gotten some wins, and you don't get the wins if you don't try, and you can't try if you don't have the time. And this is one of the ways you can buy yourself time in a division or a department where you don't necessarily have that support up front.
And thank you very much, Dr. Wallach. I think one of the things that we strive to do within research administration, the clinical trials division, and all the supportive leadership, and working with PIs such as yourself, is that partnership. And I think that gets lost, right? Because we're not an island. So it doesn't matter what we're doing on the ground if we don't have clinicians who are interested in doing this work. And it doesn't matter how much you want to do as a clinician who wants to do research and clinical trials specifically, if you don't have a clinical trials division and all the access to the resources and tools that we're struggling to provide. So I think we've come a long way, at least, like I said, since I've been here in 2014. I know that we have, further to go, but it's that partnership, right, that enables you to succeed and us to succeed. And most importantly, for our clinical trial patients, it's them, and that's why we're all doing this. So thank you very much.